Welcome to the University of Michigan Dentistry Podcast Series, promoting oral health care worldwide.
This afternoon we have an opportunity to examine a young lady who presents a little swelling of the gingiva, among some other interesting diagnostic problems.
Tell us, Alice, to begin with, when you first noticed this, and has it caused you any pain or anything like this? When did you first see this bump?
Well, it was about a month ago, but I didn't think anything of it because it didn't hurt.
Mm-hmm. And it seemed like it was something that's pretty normal to you at that time.
Yeah.
Then did you notice a beginning? Did it grow? Did it become larger? Did it cause you any pain?
Well, yeah, it did. It did get a little bit bigger,
Mm-hmm.
and no, it didn't cause any pain at all.
And it has not caused you any pain at any time?
No.
I think if I can recall correctly, maybe we can take a look now, Alice, if you can lean your head back here. I would like to take a look, and we might have the class notice that this is the area we're talking about. I think you can see the swelling is directly behind the cuspid and the lateral. There is a good view of it there. I think you should be able to see in your picture that the cuspid has erupted through this area and that the tissue here is a rather healthy pink color, and it does not appear to show much in the way of inflammation at all. There are a couple of significant things to see, and certainly those are probably the two: the eruption of the cuspid and the color of the tissue overlying the elevation.
How old are you? Did we ask you that question already?
No.
Okay, how old are you?
10.
10 years old. Okay. And this, Dick, to recapitulate, has been here for a couple months. Is that right?
Yeah, you might mention, however, Alice, that you're almost 11. You'll be 11 in April. Is that correct?
Yes.
So we'd really say you're closer to 11 than you are 10.
Yeah.
I think there are a couple of important things here. Certainly one is that the mandibular cuspid usually does erupt around 10 years of age, so her eruption sequence and her eruption chronology is good. There appears to be no retarded development here at all, and I think this is important. There also, if you can recall, and maybe we should show this again if you want to zoom back in for just a moment. If you do look in this particular area, I think I'll just retract and let them look down here. I think you probably don't need to show the lesion. What I want to show here is that she has pretty good alignment. There is no appreciable displacement of this cuspid right here by the lesion. In other words, the eruption is taking place rather normally. And I think we do want to utilize this information too to recognize that whatever is causing this swelling is showing no appreciable pressure on the tooth that's erupting. So maybe at this point in time, Dr. Rowe would like to take over and make some possible suggestions. I think we're starting to work our way toward some kind of a differential diagnosis on what Alice's lesion is.
Right, Dick. As I see the patient, when you called me and I came in here, I see a very attractive 10-year-old girl that has a nice dentition, and here is something that doesn't belong there, and the question is, what will it do if left alone? What is its natural history if we ignore this growth? Does it present a problem? What kind of management is needed? And of course, in order to get those answers, we have to know what is this lesion. Now, there's a surefire way to do it, and that, of course, is to remove it in biopsy. But I always like to go through the testing procedures, beginning with the least destructive, least costly, least time-consuming, and work our way down to the last one, which gives us the final definitive answer, which is biopsy. So the first one is to look at the mass, and the inspection reveals this to be an enlargement that is fairly firm. Its color is that of the normal mucosa. The next question, the next test that we apply is to ask the patient, how long has it been there and what is it doing that you can see? She's described that it's asymptomatic. It's been there not too long as far as she's aware of it. So this does imply the mass is perhaps enlarging slightly in size, but not at a very rapid rate. From here, then, we go on to other procedures, but I think we have the next one available, and that would be the X-ray.
Well, I think you can see right here that there is a little white lesion that almost looks like a four-leaf clover. And you can see the difference in the two views. Change in horizontal angulation does show it to be resolved a little off this present position, which shows it almost directly behind the lateral. With a little change in angulation, it looks like it's more between the two teeth. I don't think the position is that important, but you can see that there is a radiopaque area there looking about like four-leaf clover. And we think this, of course, is an important finding. It should be quite obvious to you that there are two things that tend to rule out a cyst, mainly because the tooth has erupted despite this, whereas with a radicular cyst, it will be quite rare that a tooth would erupt through the radicular cyst area. The other thing is you do not really see any great bone involvement at all. There may be right at the tip of the alveolar bone, but I even have some question about that. And so it looks like this lesion is dictated by what you see here. And if our tentative diagnosis is that this is an odontoma.
Yeah, I think at this point we should say, what are the possible lesions which could produce such a lump in Alice's mouth? And I would say that just playing the odds without ever seeing a patient, in other words, answering a telephone conversation, you would say this is an inflammatory mass. For example, the pyogenic granuloma would be a very good candidate just based on frequency. Here's a little girl that probably eats popcorn while watching television. She may have slipped a popcorn hull down behind this cuspid tooth, and the mass that is lingual to the tooth is a hyperplastic reaction to the low-grade irritation of this popcorn hull. Popcorn hull is particularly suspect because she's the right age to eat this, and secondly, the hull is a concave, springy type of material which will adhere to teeth. And once the air is pressed out, it's like a little suction cup. It'll stay right there and be an irritant. Well, the color of the mass and the consistency of the mass is not quite right. It's not boggy, it's not spongy, it's not red, it doesn't bleed. So that would slow us down in thinking in terms of an inflammatory hyperplasia, whether it would be a pyogenic granuloma, fibroid epilus, or what you would wish to call it. The next category I think that we ought to consider, and that is the category of neoplasia. I think all of us think first right off in a patient, is it cancer or is it not? This is a question that statistically is a very remote possibility, but to Alice's mother, remote though the possibility may be, she wants the answer to that one. And so we think of the benign and the malignant neoplasia. Malignant would be discounted here because it's grown too fast, or rather too slow to be a malignant neoplasm, because the patient's been aware of it for a period of months and it hasn't seemed to increase too much in size. So we're left thinking then in terms of benign neoplasia, and here's where Dr. Corcoran's explanation of the X-ray has been tremendously helpful. Because as he points out, there is evidence of calcification in this mass. And if we can go back to that X-ray for a minute, let's look at some of the very fine features of the calcification. First of all, this little mass, which we encompass here, seems to have some little points. One little point, one little point, one little point, one little point. In other words, there seems to be 4 definite little spiky projections. And in the center, there's almost like a little dark H. I think if you use your imagination here, there's almost like a little dark H. Now, things that appear calcified could either be bone, or perhaps cartilage with calcification, or tooth structure. And in this case, tooth structure would seem to be the most logical, because there is the morphology here to suggest something like, say, root canals and tiny cusps or cusplets. And then in the differential diagnosis, you have to say, all right, this is a small supernumerary tooth, just lingual to the cuspid, and Perhaps that's one possibility. Another would be, as Dr. Corcoran's pointed out, the odontoma, two varieties, compound and complex. We put them in that order because they probably represent a continuum. The supernumerary tooth being a well-defined entity. If it's very small and if there's another anomaly along with it, just like two small teeth, then you're into the compound odontoma group. And if you keep the same components there but intermix them, scramble them up, then you're still dealing with an odontoma, but now you call it complex odontoma. So I expect, Dick, that when this lesion is finally diagnosed, we will see under the microscope evidence that it is in fact a compound odontoma. I think the biopsy procedure the pathologist looks at, so he looks at the pedodontist and says, is there an advantage or a disadvantage to the removal of this mass for a biopsy purpose? And then, of course, let's suppose it is an odontoma. What's the treatment for odontoma? You want to tell us a little bit?
Well, I think that the treatment in this particular situation is complete removal. That there's probably no doubt but this will continue to grow in size and will become more organized. And although it is not an immediate critical thing to be removed, I think that it's well to remove it before the area does become larger and a great deal less convenient for Alice to manipulate and chew and talk and the various things that would be impeded by this growth continuing to get larger. So there is no doubt about the fact that it should be removed, and complete excision is the best solution to the problem.
What do you, if the lesion were left in there, let's suppose she hadn't come to her dentist to have this thing diagnosed, what would you expect the natural history of this growth would be?
Well, I think it's a little variable. Generally, I would suspect that it will get larger and become more cumbersome as time goes on. I can't anticipate that it would become enough of a problem that it would cause separation or movement of teeth, but it could.
Yeah.
I've seen them where as a matter of fact, I can recall removing one time that had elements of 21 teeth in it. 21 little supernumeraries or whatever you want to call them within an odontoma. And it's fairly certain that it will increase in size, and it's best for the patient and easy at this period to remove it and get it out of there. And I think this is what Alice is in favor of too, as a matter of fact. And I think this is the course by which we would proceed.
Yeah, okay. If you leave this in there and exhaust the growth potential of the odontoma, assuming it'll just stop growing at some stage, may already have exhausted its growth potential now.
Could be.
She still, by virtue of the lump, could impact food and so on between it and the tooth, and this then gives you a superimposition of the chronic inflammatory process, which could make the mass quite good-sized.
Well, I think also, particularly in children, the tactile sense of the tongue makes anything in the mouth that's not normally there feel like the size of a cannonball. And I'm sure that Alice recognizes that that's an area that's large and shouldn't be there, and probably does have a tendency to play with it with her tongue, too. Alice, how about it? Do you seem to notice working more on that side than on the other?
Yeah.
Yeah, I think this is about the way it goes. How do you feel about it? Tell us at this point.
Well, I think it should be taken out because it might just sort of wreck up the way my teeth go and the way they're in line. And, well, it'd be neat to have it out so you could look at it.
Well, I think you're on the right track, Alice. This is the way we feel about it, too, and it is not a real difficult procedure. And I think you'll be much happier to have that removed and get that back down to a normal configuration so that it feels normal.
Good.
You've been listening to a presentation from the University of Michigan School of Dentistry, which is dedicated to supporting open learning and open educational resources. This recording is licensed under the Creative Commons. It may be reused and redistributed for nonprofit use. Please attribute materials to the University of Michigan School of Dentistry and redistribute under this same license. For more information on how this and other University of Michigan School of Dentistry recordings may be used, visit www.dent.umich.edu/license.